All right, let's talk about Klinefelter Syndrome. We will review the pathophysiology, clinical presentation, and management. Klinefelter Syndrome is the most common genetic cause of primary hypogonadism, occurring in approximately 1 in 1,000 live births. It occurs as a result of extra X chromosomal material, and we'll talk about this shortly. So what are the typical karyotypes? There's a 47XXY, which is the most common, and this is actually called the classic Klinefelter, and occurs as a result of non-disjunction during gametogenesis. This occurs in the parent. And what is a 48XXXY? This is actually more severe phenotype due to the extra X chromosomes present in these patients, so they have more severe low testosterone and significant gynecomastia and other signs of insulin resistance, etc. And then there is a mosaicism. Well, so mosaicism actually results from mitotic errors which occur in the zygote, that is post-fertilization, obviously, with an initially normal chromosomal complement. So the initial zygote is normal, and then you do have these mitotic errors during subsequent divisions. The extra X chromosome produces little to no abnormality until adolescence in these patients. And then there's 46XX, which is actually a male. So you might say, well, where is the Y chromosome then? And it's important to realize that there's actually a translocation of the SRY translocation from the X chromosome, and this is what allows them to have the male phenotype. So it's a presence of SRY being translocated from the Y chromosome to the X chromosome that allows 46XX males to be present. So phenotypically they look like males, but they do have a 46XX karyotype. And then there's a 47XYY, and these are typically phenotypically normal males, and they are often fertile. And remember that the difference between this karyotype and the rest is that they do not have the extra X chromosome, and this explains why these Klinefelters actually appear phenotypically normal and are often fertile. It is, however, important to realize that patients with 47XYY karyotype do seem to have an increased risk for learning disabilities, delayed speech, and language development. So we did discuss the various errors earlier. So the pathophysiology is that it occurs around adolescence, and patients do have a small firm testes, dysfunctional Leydig cells leading to poor testosterone, intratesticular testosterone production, and as a consequence, due to low intratesticular testosterone, these patients develop azoospermia and infertility. Decreased testosterone production also leads to a small phallus, because this is important during pubertal development, and low testosterone leads to gynecomastia as well, and the delayed epiphyseal fusion due to absence or low levels of testosterone and subsequent estrogen leads to the unicoid body proportions. So what are some of the hormonal changes? Well, due to low testosterone, reflexively there's high LH and FSH. These are the gonadotropins. Okay, so primary testicular failure from Leydig cell dysfunction leads to elevated LH, and then damage to the seminiferous tubules also leads to high FSH. Decreased testosterone, or sometimes low normal testosterone, due to impaired production of testosterone in the testes. Estradiol may be normal or slightly elevated. Remember that testosterone gets converted to estrogen in peripheral tissues by aromatase enzyme. And then inhibin B is also decreased, and this is a result of damage to Sertoli cells. Remember that the Sertoli cells are responsible for sperm production and also production of inhibin B. Okay, so this is actually a summary of testosterone production. So remember that GnRH levels increase, and then so do gonadotropins, FSH and LH. And then this goes to the testes, Leydig cells, stimulated mainly by LH, and FSH stimulates mainly the Sertoli cells. And of course, the Leydig cells produce testosterone, Sertoli cells produce sperm and inhibin B. And in Klinefelter syndrome, due to damage to the testes, testicular damage, both the seminiferous tubules and the Leydig cells are damaged, resulting in low T and low sperm count as well. So the clinical features, they do exist in a spectrum. It can range from moderately severe unicoidism to a near normal male phenotype, as we mentioned earlier. And gynecomastia is also quite variable. The histopathology, there is sclerosis of seminiferous tubules. There's thickened basement membrane of these seminiferous tubules, and there's evidence of damage to the Leydig cells. And all of this tends to occur post-adolescence. Okay, so usually pre-adolescence, the testes are normal or near normal, and you wouldn't see these changes on histopathology. So what are the other clinical features? They do have cognitive behavioral problems and increased depression and learning disabilities, and they are at risk for some metabolic and non-metabolic issues. So diabetes mellitus is very common in these patients, and also screening for cancers, because on occasion they can develop mediastinal germ cell tumors, and these are usually in the chest. Okay. So anterior chest, I should say. So an anterior chest mass, it's important in these patients, can present with new onset asthma symptoms in some patients, or trouble breathing, and it's important to consider this as a differential in your workup. So this chart literally shows the production of endogenous testosterone. We all produce about 5 to 7 milligrams of males, produce 5 to 7 milligrams of testosterone a day, and it has effects in the liver, in the muscle, skin, and bones. Okay, effects in the bone are mainly regulated by estradiol, and then effects in the skin mainly affected by dihydrotestosterone, which is produced after the conversion of testosterone to DHT by 5-alpha reductase. And then testosterone is also important for muscle growth. Okay. So what is the 46XX? We mentioned this male variant earlier, the fact that they do have the SRY gene translocation from an X chromosome, and that is the reason why they are phenotypically males. However, these patients do have hypospadias and a short stature. Okay, so this is one for the boards. Short stature in a patient with Klinefelter, you have to think about 46XX. It's a common trick question. And then how about 47XYY? They are more typically normal males. They are usually fertile, but as I said, they do have some neurocognitive challenges, including speech and language delays and learning disabilities. So what are the key laboratory tests? We do take a peripheral leukocyte karyotype from a blood sample, and this confirms the extra X chromosome. Example, the classic 46XXY. And LH and FSH levels are typically elevated due to damage to the Leydig and Sertoli and seminiferous tubules, Sertoli cells. Testosterone levels tend to be either low or low normal. Inhibin B tends to be decreased. Remember that this is produced mainly by the Sertoli cells. And when you do perform a semen analysis, these patients tend to have azoospermia. The key management is testosterone and replacement. This improves hair growth, muscle mass, and bone density. Remember the effects of testosterone, okay, that we discussed earlier, effects of testosterone. And remember that in the bone, It's mainly from estrogen effects in the muscle. It's mainly from testosterone working on androgen receptors in muscles, in muscle fibers. And then in the hair follicle is mainly DHT working on the hair follicle to increase follicle proliferation. So the dose of testosterone is adjusted to maintain the mid-normal male testosterone level. We don't want to over replace these patients. And unfortunately, most of these patients do have azoospermia and are infertile. However, remember that 47XXY and 46XY may have some residual spermatogenesis. And then counseling is important, especially in support, especially in these patients who tend to have learning disabilities and various psychosocial problems, and they are at risk for breast cancer and other comorbidities. Remember the germ cell tumors in the thorax, so it's important to have a low threshold for screening for these patients. And then always require genetic counseling, recommended for the variant karyotypes, because as I mentioned earlier, their presentations might differ in terms of their risk factors. So the key takeaways are Klinefelter syndrome is the most common cause of hypogonadism, primary hypogonadism in males, usually presenting after adolescence. There are variable phenotypes which can range from severe unicoidism to almost normal male appearance. And remember that phenotypically normal appearing males could actually have undiagnosed Klinefelters due to mosaicism or other variants such as the XYY variant. And then they do have elevated gonadotropins, LH and FSH, and very low testosterone or low normal testosterone. Patients do have gynecomastia and infertility, and our management is always to replace testosterone mainly for muscle development, bone health, psychological state. And also remember that these patients do require psychosocial support and genetic testing. Thanks for joining me on today's video. If you found this helpful, kindly subscribe and like, and also share with others, and I'll see you on the next video.